Welcome to this explainer. Today we're stepping right into the intense, incredibly high-stakes world of acute cardiology. We are talking about those razor-thin margins in the ER and the wards, where recognizing clinical boundaries isn't just some academic exercise. It is, quite literally, a matter of life and death. In these critical moments, your baseline knowledge and rapid pattern recognition, that's the only thing standing between your patient's recovery and an irreversible disaster.
Okay, let's dive into this. Picture the scene. Alarms are blaring, your patient is pale, and they're complaining of crushing chest pain. You check the vitals, they're hypotensive, and you notice their jugular veins are really prominently distended. Now, your gut instinct, which has been drilled into you for acute coronary syndrome, might be to immediately order a nitroglycerin drip to relieve the chest pain and ease the cardiac workload. But pause right there. If you push that medication right now, before finishing your assessment, did you literally just make a fatal mistake?
Section 1. The preload boundary. Navigating the 50-50 dilemma.
This boundary is the exact tipping point between treating left ventricular failure and right ventricular infarction. And getting this 50-50 dilemma wrong, it's one of the most common and, frankly, most devastating execution gaps in acute care. Let's break down the physical exam, because this is exactly where the paths diverge. In left ventricular failure, the left side of the heart is failing as a forward pump, right? The result is acute fluid backup. Blood pools behind the left ventricle, essentially flooding the pulmonary circuit. When you listen to the lungs, you're going to hear prominent rales, maybe an S3 gallop, and the patient is probably struggling to breathe when they lie flat. But a right ventricular infarction, that's a totally different mechanical crisis. Here, you've got a profound, acute loss of contractile volume on the right side. The right ventricle simply can't push blood forward into the lungs. So what happens? You get severe hypotension because blood just isn't reaching the left side of the heart to get pumped out to the body. You see that elevated jugular venous distension because everything is backing up into the systemic venous system. And the absolutely crucial detail here, the lung fields are completely bone dry.
Now, what's really interesting is how perfectly the medical boards test this exact boundary. Take this classic scenario. You've got a 64-year-old woman, history of hypertension and diabetes, presenting with shortness of breath and hypotension. Blood pressure sitting at 90/50. But catch this key finding. The lungs are clear to auscultation. Despite her distress, there's absolutely no pulmonary edema. So, in this specific presentation, choosing to administer nitroglycerin, that is a lethal error.
To avoid falling into that trap, you've got to run a rapid signal versus noise audit on the EKG. First, you isolate the true signal. Right ventricular infarctions usually ride along with inferior wall MIs. So you're looking for ST elevations in leads I, 3, and AVF. If you spot those, you have to actively seek right-sided corroboration. Get right-sided EKG leads and specifically hunt for ST elevation in lead V4R. At the exact same time, you have to completely tune out the noise. Things like nonspecific ST depressions in anterior leads, like V2, can be super distracting. They pull your eyes away from the primary pathology. You just have to remember the mechanics. An infarcted right ventricle is basically just a passive conduit. It relies almost entirely on preload to maintain any sort of forward cardiac output.
And that brings us to our first major clinical rule. The absolute dumb mistake you can make here is giving nitrates or diuretics to a patient with a confirmed right ventricular myocardial infarction. Nitrates cause venodilation. If you drop the preload in a patient who relies entirely on venous filling pressure to passively push blood through the pulmonary circuit, you're going to completely eliminate their cardiac output. You will immediately precipitate profound iatrogenic cardiogenic shock. When you spot an RVMI, you have to pivot away from nitrates instantly and initiate aggressive intravenous isotonic fluid boluses to keep that vital preload up.
Section 2. Tachyarrhythmia mechanics. The hemodynamic stability matrix.
Okay, so now that we've secured the volume mechanics, we're shifting gears from the plumbing of the heart over to its electrical grid. When heart rates skyrocket past 150 beats per minute, your decision-making window shrinks from minutes down to seconds. And the absolute diagnostic dividing line here isn't just about what the EKG looks like, it's about structural end-organ perfusion. To evaluate this in seconds, we use the deciding vector mnemonic, CASH. Does the patient have ischemic chest pain? Is there an alteration in mental status? Are they experiencing severe shortness of breath, or are they hypotensive? If any of these CASH criteria hit positive, well, the patient is hemodynamically unstable. You're no longer in the realm of pharmacotherapy. You have to move to immediate electrical intervention.
So, the crucial point is how we map these interventions to the patient's exact status using a resuscitation matrix. If the patient is stable, meaning they've got a wide complex monomorphic ventricular tachycardia, but their blood pressure is totally fine and they're fully alert, you actually have time. You can use antiarrhythmic infusions like IV amiodarone or procainamide. Now, if they are emergent, meaning an unstable tachycardia where they're cash positive, maybe confused or hypotensive, you must deliver immediate synchronized electrical cardioversion. But if they cross into the critical stage, pulseless VT or ventricular fibrillation, you completely bypass synchronization. You go straight to immediate unsynchronized defibrillation.
And let's be super clear about why that distinction physically matters. Just picture ventricular fibrillation. This isn't just a fast heartbeat, right? It is absolute kinetic chaos. The myocardium is just quivering in this disorganized, rapid way. Texts often describe it as looking like a bag of worms. Because the electrical activity is so completely chaotic, there's no discernible P wave, and crucially, there is no stable regular R wave.
Which leads us directly to our second major clinical rule. The dumb mistake here is attempting to perform synchronized cardioversion on a patient in VFib, or polymorphic VT like Torsades de Pointes. Think about how synchronization works. The defibrillator reads the EKG, locks onto a stable R wave, and delivers a shock at the exact millisecond needed to avoid the vulnerable T wave. But in VFib, there's no R wave to lock onto. If you hit the sync button, the machine is just going to sit there endlessly searching for a signal. It'll fail to deliver the life-saving shock while precious seconds just tick away. Or worse, it misfires and compounds the chaos. For VFib, you must deliver an unsynchronized, high-energy defibrillation immediately. No waiting.
Section 3. Unmasking sudden syncope. The executional pearl. Let's step away from the acute emergency bay for a second and look at the diagnostic cardiology wards, where the execution gaps are a lot subtler. Picture a patient who had an unprovoked sudden drop attack. They literally just passed out of nowhere, zero warning. But right now, they're sitting in front of you looking perfectly fine, and their resting 12-lead EKG is pristine, totally normal. The temptation to just reassure them and send them home is incredibly high. But you have to ask yourself, does that normal resting EKG completely rule out a fatal structural or arrhythmic driver?
And this brilliantly illustrates our defining executional pearl, pulled straight from the medical literature. Quote, unless there is a clear vasovagal syncope in a young patient, place all patients on telemetry or Holter monitoring to evaluate for arrhythmia. End quote. A single normal EKG just isn't going to cut it.
Let's connect the dots on why this is so absolutely critical. Think about it. A resting 12-lead EKG is just a static snapshot. It captures exactly 10 seconds of electrical activity. That is it. 10 seconds out of a 24-hour day. It's going to completely miss kinetic, episodic events like paroxysmal ventricular tachycardia that only flare up intermittently. It can't reliably exclude an intermittent conduction failure, like a highly unstable block that suddenly drops into complete heart block but resolves before the paramedics even show up. The only correct execution choice for unprovoked syncope without a clear benign cause is to mandate real-time kinetic mapping. You need a 24-hour Holter monitor or an implantable loop recorder to catch these fatal conduction drops right in the act.
Section 4, the final audit. Are you ready?
We've covered a massive amount of ground today. We've defined the absolute boundaries of right ventricular preload, mapped out the rapid decision trees for tachyarrhythmias, and unmasked the hidden dangers of syncope. And look, these aren't just textbook facts. They are real-world mental models that save lives. So I want to leave you with this final thought. When you are the one standing at the bedside, when the monitor alarms, the blood pressure drops, and the seconds are literally ticking away, will you just see the static noise? Or will you recognize the true clinical boundary before it's too late? Keep reviewing and never stop learning. Thanks for joining me on this explainer.